Bismillahirrahmanirrahim. I'm Dr. Saeed Rafiuddin Shah. Today's topic presentation is investigations, radiological investigation, IVU, CT, and MRI. So let's start from some healthy activities. A 21-year-old male presented in OPD 14 with complaints of right flank pain radiating to back with a positive family history of renal stones. Examination was unremarkable. Ultrasound KUB done in OPD showed a stone of 1.5 centimeter at renal pelvis with no hydronephrosis in heart ureter. So
it's an interactive session हो सकते हैं, so please participate. अल्ट्रासाउंड हो चुका है, पेशेंट की फैमिली हिस्ट्री है, स्टोन है, पेशेंट को अब क्या करना है? Why CTKUB? So you have the point कि जी CTKUB because of the family history, ठीक है? R1 scenario ये है. What are the initial investigations after ultrasound KUB? उसका rationale ये था कि family history of stone disease था. आपका rationale क्या है for a CTKUB? Why not other investigations? मैं इमेजिंग की बात कर रहा हूँ, CPUC की बात नहीं कर रहा हूँ, ठीक है? एक्सरे स्कल, एक्सरे एब्डोमेन, एक्सरे पेल्विस, एक्सरे. So be specific now. Why X-ray KUB? We already have this kind of stone of ultrasound हो सकते हैं with a stone of 1.5 centimeter, single stones. X-ray KUB क्यों करवाना चाहोगे? What's the rationale? Why CT KUB? पता चल गया. It's 400 Hounsfield unit. Then the Hounsfield unit is 400. So ESWL, ठीक है, आपने केस प्रेजेंट कर लिया. Anyone?
any senior?
नहीं, अभी सीनियर पे बात आते हैं. The stone density when you perform the CTKUB, the stone density was 300 or 400. So तो thousands की तो बात ही नहीं हो रही ना, अभी तो 300 400. अच्छा, you go for CTKUB हो सकते हैं to check the Hounsfield unit हो सकते हैं. Dr. Kausar, please. The scenario is a single stone of 1.5 centimeters, non-hydronephrotic kidneys. So, what do? What is the initial investigations?
Sir, initial investigation is CTKUB.
Why?
To see the exact size of a stone and location as well as the Hounsfield unit, so that we can decide further plan accordingly.
Okay, again, the scenario is if the Hounsfield unit after CTKUB, it's 300 to 400. So,
Sir,
management पे कोई फर्क पड़ेगा या नहीं पड़ेगा? My simple
sir, since the size of the stone is 1.5 centimeter, we can give a trial for ESWL.
Okay.
We can get a better outcome with this.
Dr. Daniel, please, can you comment on this scenario?
I would advise X-ray KUB to show whether the stone is radio opaque or radiolucent.
Yes, that's the point. Is that to stress X-ray KUB after ultrasound हो सकते हैं. The scenario is your OPD, the OPD 14 हो सकते हैं. You are in the OPD 14, and this is the case scenarios in which after ultrasound हो सकते हैं, go for X-ray KUB. X-ray KUB is not obsolete हो सकते हैं, because when you perform a CT KUB हो सकते हैं and the Hounsfield unit is 300 to 400. So when you advise or plan for the management is ESWL. Then what kind of ESWL? Under flow or ultrasound guided? There is a difference. If you simply write it down that ESWL with the Hounsfield unit of 300 or 400, so fluoro पे तो नहीं आएगा. So make sure that ultrasound. And so on your management plan, ultrasound guided ESWL or fluoro guided ESWL. Okay, thank you.
So the next question is, what is the investigation of choice for this patient? A single stone in renal pelvis with no hydronephrosis, no hydrourator, came in OPD 14.
Dr. Shersha, can you comment on that?
So, the most commonly which is available is ultrasound, but since it's not in the option, so we'll go for CT-KUV because he's a positive family history, and we've also seen a stone on ultrasound. So if it would be radiolucent stone, we would miss it on X-ray KUV. And for us to be sure, we'll get a CT KUV done to know the exact stone size, its Hounsfield units, its exact location inside the kidney, and the renal anatomy, so we can go for the further management plan.
Why not X-ray IVU or CT urogram or MRI Euro?
Stones are not well appreciated on CT urograms with contrast enhanced studies.
Dr. Fahad?
Sir, investigation of choice would be CT urogram.
Is there any limitation of CT urogram?
We know the patient creatinine.
Renal function, you have to
Renal
know that
function.
the renal function is that. If the patient is in renal failure,
Then
secondary to stone
CT.
disease, so will you perform that?
No. In renal failure, I will go for CT KUB.
Okay. If the scenario is a pregnant lady of 3 or 4 months pregnant, then Dr. Daniel, any of these investigations, will you perform that in a pregnant lady of 3 to 4
So
months?
MRI.
You, Dr. Bafawar, आपका क्या comment है? She's a pregnant lady. जी, Dr. Misal. Hi.
Sir, in case of a pregnant lady, we avoid radiological investigations unless the risk is lesser than the benefit. So if we have a stone that is of 1.5 centimeter, it is not causing hydronephrosis or hydroureter as of now, and the patient already has a history of stones, maybe we can skip the investigation and manage the patient conservatively unless and until there is a deterioration of renal functions or the patient's condition worsens, like they develop hydronephrosis or something, then maybe we can.
Okay, these are the investigations. Now we will discuss that in different scenarios. What investigations you advise for? Okay.
So the aim of today's lecture is some lights on contrast medias, IVU, CT, and MRI. And my aim is to show you people more pictures of radiology. So iodine contrast media. So most of the urography depends on contrast media. So there are types of contrast media: water soluble and water non-soluble. High osmolality contrast media that most of the time we in urology use is gastrographin. And the other contrast media is Conray, cysto-Conray. Low osmolality contrast media are ISOWAVE, Omnipac. Omnipac, we also use Omnipac and UltraVest, and most of the time. Isosmolar contrast media, Vesipac, these all are the trade names used in Pakistan. So water insoluble contrast media, these are lipid-based contrast media. We mostly used and some a CT scan. And the standard dose of contrast media in adult are 50 to 100 ml, and pediatric dose is 1 ml per kg. So urographic techniques are intravenous urography, CT, tomography, and MRI, MRU. So the first one is intravenous urography. It's a radiographic study of a renal parenchyma, peleochalaceal system, and ureters, and the renal bladder, in which IV contrast is given and X-ray image is taken at various times. It shows structural and functional evaluation of urinary tract. It's nowadays almost completely replaced by CT and MRI. So the indication of IVU are renal to see the renal collecting system and ureter, any obstruction at a ureteral level, fistula and structures, intraopicification of calyceal system for ESWL or percutaneous nephrolithotomies, and renal functions in emergent situation while you are in trauma patient most of the time, and unstable patient with the renal grade 5 injury. So on table-based IVU is important to see the other kidney. Renal and ureteric anatomy and special circumstances that is PTOSIS or floating kidney, a condition in which kidney descend more than 2 vertebral bodies are greater than 5 centimeters during position changing from supine to erect. And some congenital tract abnormalities like DUPLEX, malrotation, horseshoe, and ectopic ureters. IVU can also tell about the transitional cell carcinomas, a space occupying lesion in pelvis, and complex urinary tract infections like TB. So there are contraindication of IVU. The absolute contraindication is past history of severe contrast media reaction that are with high osmolar contrast risk is 20%, and low osmolar the risk is 5%, and any proven hypersensitivity to iodine. The relative contraindication are more is like asthmatic patient, beta blocker, chronic renal insufficiency, cardiac disease, diabetes. Metformin therapy is very important. Where before contrast, you should take the history of diabetes and the history of metformin, because these patients with any increase in renal failure, these goes in contrast based renal insufficiencies, sickle cell anemia, thyrotoxicosis, or pregnancy. So the IVU phases, films and phases. So the first of all, we took a scout film, which tells about the bowel preparation, correct position, exposed kidney and bladder stones. The next immediate film is a nephrogram phase, taken immediately following IV contrast, which tells about the filter contrast with an lumen of proximal convoluted tubules. And the next film is pyelogram phase. A contrast gets concentrated in long tubules, and a film taken at 5 minutes and then regularly at 5 minutes interval until the question that promoted IVU is answered. So the next film is 15-minute compression film, and the other is 15-minute release film and post-wide film. The post-wide film shows about the prostate enlargement, bladder filling defect are due to stone urothelial cancers. So the side effects of IVU is the most common is anaphylactic reactions, nephrotoxicity, and contrast-induced nephropathy. So these are the control film, and this you can see the limits of KUB, bowel preparation, and pre-existing pathologies. Is there any calcification and calculi? So then after that, you can compare with the immediate film as a nephrogram phase. It's always an epi-view film, and immediate we took this film immediate after IV contrast. So the aim is to see the renal outlines, a nephrogram phase, a renal outline. Next film is a 5-minute film. It's called as pyelogram. It's determined the excretion as is symmetrical or asymmetric excretion from both kidneys, or either we need further contrast to enhance pelvic urethral system. The aim is to see the pelvic urethral system in this. So the compression technique. Sometimes we need compression to see the pelvic urethral system. So and IVU. So we compress the abdomen. The rationale of compression is to stop the drainage of the ureter. So the pelvic urethral system will be 5 more. So compression enables the ureteric drainage and promotes distension of a pelvic urethral system, optimize their visualization. So you see before compression, the pelvic urethral system, and after compression. There's a lot of difference between before compression and after compression. So contraindication of compression. So you can't do compression in every patient. So there are contraindications. When always 5-minute film shows already distended calyceal system, so there is no need of compression. A recent abdominal surgery, a wide compression, abdominal aortic aneurysm, acute painful abdomen, urinary tract traumas, presence of urinary diversion, and presence of renal transplant. So a wide compression. Post-fight film. Post-fight film, the aim is to assess the lower tract. It's a bladder, a return or diagnosis of VJ calculi, bladder stones, and urethral diverticulum. So these are the some pictures taken according to base of IVU. The one is you can see the complete duplex, compound calyceal systems are stone, or there is a defect, filling defect. You can see the horseshoe kidney, the pelvic kidney, and the dilated ureter secondary to stones, small atrophic kidney. And this is compound with a small nerving at PUJ, and this complete PUJ. Again, a small atrophic kidneys, compound calyceal systems. This is a primary megaureter, absent kidney. That is a mass that deviated the right calyceal system and ureter. And this is the next is a partial, or we can say the bifid pelvis on left side. Again, a upper tract, suspicious of upper tract TCC or failing defect, you can see. This is a deviation of ureter, some internal pathologies, extramural, and look at this. Multiple structures of complete ureter. Most the common is renal TB. Anyone can tell about this? Any reason?
Dr. Zafar.
Sir, I see a dilated portion of left ureter more as compared to the right one. I think there is some sort of distal obstruction in the left, in the course of left ureter, near to its distal third junction, that is near the VUG.
So it's a distal ureteric stone, obstructed
I need
ureter
a
stone with
plain-
dilated system.
I need a
It's a
plain.
failing defect.
Yeah.
Yeah. So you have to compare this image with the scout film. Anyone can explain this? Again, a failing defect in ureter with dilated mid-ureteric calculus with mildly dilated calyceal system.
It's a proximal. ureter.
Approximate. Anyone senior resident can tell about this?
Dr. Babar. What do you see in the supine position and what you see in the upright position?
So in supine position, we can see the contrast and nephrogram, and contrast draining into in the right side of the right image. Contrast is draining into the ureter, and in the left side, the contrast is not draining into the ureter, but pelvic calyceal system is dilated. On the right side, there's a there's a nephrogram, and we can see the contrast, but kidney is not at its normal position. And on the right side, there's a contrast which is draining to the bladder.
What do you mean by ptosis of kidney?
Yes, sir.
Ptosis of the kidney. Can you appreciate the difference of position of the kidney? That's
Yeah.
why I mentioned that is a kind. What are the findings in the supine, and what is the difference in upright position?
So in the supine position, the kidney is at its normal anatomical position, but in upright position, the kidney is a little lower in the right side.
Yes, it is
Yes.
floating ptosis, floating. So this film shows the bilateral duplex system and IVU. You can see the bilateral ureter, separate ureter. Any senior resident can tell about this.
Dr. Najib, can you comment on this? What are the findings? Don't go for diagnosis. What are the findings
Sir, I can appreciate dilated pelvic system on the left side. Contrast, I can appreciate in the urinary bladder, it's creating, but on left side, it's more prominent and on the left side near VUJ.
What is this? This.
There is a filling defect on the left side near VUJ.
Dr. Faisal, can you comment on?
Like Dr. Najib said, there seems to be two pelvic ileal system opacifying on the left side and a single one on the right side. And there is also a filling defect at the left VUJ. It is also known as a cobra head sign, which is a suggestive of uretrocele.
So this patient has a partial duplex systems along
Yes.
with the uretrocele on left side, right?
Yes.
Ectopic ureters. Ectopic ureters are somewhat an IVU. We call these signs are drooping lily signs. Lower pole might be displaced inferolaterally by an upper pole hydronephrosis occurs due to obstruction of upper pole mighty ureter at its orifice situated with ectopic insertion of uretrocele, mostly at bladder. Horseshoe kidney. Often the horseshoe kidney can be visible on IVU and plain X-ray, but to see the nephrogram, we can be advise IVU. It's a floor vase appearance. What is floor vase? A flower vase. Gamla. A cross-fused renal ectopia. Cross-fused renal. This is the picture of IVU. So both kidneys are on same side.
What is the insertion of the ureter? Anyone tell us? In cross-fused ectopia?
Superolateral aspect of the urinary bladder.
On ipsilateral side or a contralateral side? What is the position of that?
I didn't get the question.
What is the position of the ureter insertion?
In the normal anatomy.
Many in this cross-fused ectopia. This is on the same side because both the kidneys are on the right side, isn't it?
Yes.
So what is that seems that the left kidney is migrated from left side to right side. So what is the insertion of the ureter of the left kidney or the ectopic kidney, cross-fused ectopia kidney?
It seems to be on the ipsilateral side, not on the contralateral side, because there is no contrast seen on the contralateral side. Single ureter is opacified just on the right side.
So usually, though, I think it's on the opposite way, on the same direction. ऐसे ही ना, sir?
So this picture shows a medullary sponge kidney. So it's mostly ectasia of the collecting ducts with the renal pyramids are giving panned brush appearance on IVU. So benign incidental findings are mostly associated with Wilms tumors, horseshoe kidney, or primary or mega ureter. So you can see the abnormal muscular and distal ureter near VUJ. So musculature of distal ureter leading to a failure of peristalsis. The ureter above is a normal and dilated. It's bilateral in 25% cases. Anyone can explain this?
Dr. Noman, can you comment on?
This is and delayed film with X-ray film showing contrast in bladder with an outpouching just on the right lateral side of the bladder, which might be suggestive of bladder diverticulum.
So it's bladder diverticulum, a polycystic kidney disease. So the chelical system has a classically stretched appearance due to the presence of multiple cysts and IVU. We tell this can say this as spider leg appearance. Like, so the next one is a computed tomography. CT scan is an imaging method of that produce 3D images of internal structure by recording the passage of X-rays as they pass through different body tissues, and computer reconstructed these cross-sectional images into thin slices of the body. In 1979, Nobel Prize was awarded to Alan M. Cormack and Sir Godfrey in Hounsfield for the development of CT. Nowadays, CT is an integral part of urological practice, and a CTU has replaced the IVU as modality of choice in the modern urology for hematuria, malignancy, stones, and preoperative plannings. So this is the CT machines. So anyone, what are the types of CT scan? Available at SIUT. So most of the time we are doing this.
So we are using the different CTs over there. Firstly, we do the plain CT, which are mostly using for the KUB, any stone disease or any abnormalities in the kidney. Then we will go for the contrast CT scan, which we use mostly in the oncological patient with the CT, abdomen, pelvis, and chest. And then these are the spiral, helical, and multi-detector urography. And also we are using the CT urogram for the drainage of the kidneys.
So the most common we done here is a CT KUB, a plain enhanced CT, most of for the stones. The next one is multi-detector CT, spiral or helical. These are the rapid scanning, which can scan the whole body within a breath hold. Or the old CT scan of spiral CT introduced in 1988 had a single row with detector and required multiple passes to visualize the small area of interest. So the standard scanner today has a 62 and 322 rows of detector, which allow the patient entire body to be imaged during single breath hold with a few motion or no artifacts, more precise in diagnostic accuracy, less radiation exposure. So currently the 750 rows detector are currently being developed. We don't have it in Pakistan. And some complex urology cases, the segmentation or fermenting the CT images to create a 3D rendering images can be more useful during surgery than 3D printed images. So all we इस IUT में हम कर रहे हैं 3D images. CTU. A CTU graphic is a multi-detector CT examination of entire urinary tract. Before and after administration of IV contrast include excretory phase images. It gives both anatomical and functional for information. That's why it's the investigation of choice in urology. Indicate for workup of hematuria, kidney stones, renal masses, renal colic, urothelial tumor, congenital anomalies, and hydronephrosis. Dual source CT scan, a new technique used for the diagnostic imaging, using two rotating tubes to acquire high and low voltage image, allowing the tissue differentiation, visualization of tendon ligaments, and improved CT angio and differentiation of renal stone based upon the composition. So the dual source CT can be used for to differentiate between a uric acid stone from calcium oxalate and brucite stones. This new technique is a CT fluoroscopy. It gives the 3D CT images more detail, greater soft tissue contrast, and resolution overcome the movement of the kidney during inspiration. Most of the CT fluoroscopy we can use for the fluid aspiration, drain placement, catheter placement, or cryoablation and RFF renal tumors. The disadvantage of CT fluoroscopy is radiations, increased exposure to the radiation. So the old one, CT, with a single row, is modern CT. Hounsfield unit. Anyone can define this? Hounsfield.
It shows the density of the any lesion we found on the CT scan.
Yes, attenuations value. CT image is divided into tiny blocks of different shades of black and white called pixels. Actually, grayscale of each pixel on CT depends upon the amount of radiation absorbed at the point termed as attenuation value. This is expressed as Hounsfield unit. So for the references, for air, this is -1000. For dense bone, it's +1000, and water is 0. These are the reference value. So the others, they like blood, angiomyolipomas, tumors have a specific Hounsfield units. The basic concepts of urinary tract imaging, as most of the CT urogram. We first of all took an unenhanced axial CT scan of kidney, then enhanced CT of abdomen and pelvis, and then excretory phase. So, can anyone tell about what unenhanced CT tells about? हम क्यों लेते हैं पहले?
Rephrase this question हो सकते हैं. What are the different stages or the phases of the CT contrast? जी, Dr. Dumna. What are the different phases?
सर सबसे पहले प्लेन इमेज होगी जिसमें हमारे पास विदाउट कंट्रास्ट होगा, फिर विद कंट्रास्ट एंड डिलेड फेज लेटर ऑन.
So it's true. The unenhanced CT distinguishes between different masses and uncovered stones, a renal parenchymal calcification, pre-contrast attenuation measurement of renal masses, and exclusion of hemorrhagic changes. So the next phase is corticomedullary phase, which we took, which is the phase of 3 to 70 seconds post-contrast injection. It helps and define the vascular surgery and perfusion of the kidney. The homogeneous nephrogenic phase occurs between 90 to 180 seconds after contrast injection. It allows the detection and characterization of renal masses. So the last one is excretory phase. It's occur in 3 to 5 minutes after injection of contrast. This allows complete filling collecting system and visualization of ureter. It helps in ureteral tumors, papillary necrosis, calyceal deformities, ureteral structure, inflammatory changes of the ureter and bladder. The bladder is seen best on a 20-minute and post-wide images. CT urogram is the most sensitive for detecting upper tract cancers, and one study of CTU detected 37 out of 38 urothelial cancer. Approximately 90% of malignant upper tract lesions can be detected with CTU. But CT urogram is not as sensitive as cystoscopy for the detection of urothelial tumors and a bladder. So only large bladder tumors can be visualized with the CT imaging study as a filling defect in the lumen of bladder. So carcinoma in situ cannot be visualized on CT. So therefore, cystoscopy is still an important part of comprehensive workup for hematuria. So the normal anatomy on CT. So from upper to a lower, anyone can. Okay, already I have marked this. So liver, right kidney, start, left. This is, what is this? IVC and aorta. This is spleen, and this pancreas. Again, right kidney. So अब मिड पोल पे आ जाए. Right kidney, left kidney, aorta. What these stand for? Duodenum with the pancreatic head. Again, same. And this is the, what is this? Like renal vein के उस पे level पे लिया हुआ. And this
renal artery होगा ना.
Renal artery. And what is RP represent for? Renal pelvises. We are pelvis. Or this one?
ये जो point out हुआ है इसको कोई बताएगा जी? जी? सही एग्जाम नहीं है ये.
Everything is written over there. Definitions में हर चीज मतलब हर सवाल का जवाब इन्होंने स्लाइड पे लिखा हुआ है, अगर एक्सरे भी दिखा रहे हैं तो उसका भी जवाब लिखा हुआ है, एंड इवन देन नो वन इज आंसरिंग. तो दिस इज वेरी वेरी बेसिक प्रेजेंटेशन. वो डिटेल में तो जा ही नहीं रहे हैं, बिल्कुल सिंपल. सीटी क्यों करते हैं, सीटी की इंडिकेशंस क्या है, कितने टाइप्स का होता है, ये तो सबको आना चाहिए. यहाँ R5 रेजिडेंट भी हैं, R4 भी हैं, R1 भी हैं. अगर R1 नहीं कहते हैं तो चलो ठीक है, लेकिन R2 R3 तो यहाँ है ना. सो
Again, the normal anatomy, iliac vessels, bladder. So this is a horseshoe kidney on CT scan. You can see this. This is isthmus connecting. These are MIP images of same MIP images. Duplex system. Duplex left collection system or with ectopic multiureters. We get Maer's rule states. This is the upper pole of ureter is the ectopic ureter, and its orifice inserted inferior medial in the bladder in the relationship to the lower pole of normal ureter. This is upper pole moiety with dilated ureter, and it's insert here in the bladder. Now
stands over there also. The kidney that is actually crossing the midline, ureter is not crossing the midline. Its orifice is there on that side. For instance, if the left kidney is crossing the midline going towards the right side, the left ureter will always be there with an orifice on the left side in the bladder. So this is the law. Everybody should know this law, and this is the law which should be known in the first 3 months of residency. Otherwise, it's all without any purpose. Nobody knows nothing about what's going on.
So cross-fused renal ectopia essentially refer to an anomaly where the kidneys are fused and located to the same side of the midline. These subtypes with the type as inferior ectopia, the ectopic kidney attached to the inferior pole with insertion of ureter on normal. That's type B is a sigmoid kidney, like pelvic, S-type. Type C is a lump kidney. You can differentiate sometimes like lump. Type D is L-shaped, and E is a disc like this, circular. And the F is superiorly cross-fused ectopia. These are the CT images. So अब बताएं ये कौन सा वाला है उसमें किस टाइप में आता है?
Shreechand, Dr. Shreechand, can you comment on?
Lump one.
Yes. And this one? L-shape? Again, see this.
Sigmoid.
Sigmoid. And this is the MIP pictures, the same. Urolithiasis, important topic. Except some Indian stones are renal and ureteric stone can be detected on helical CT and a standard diagnostic tool to evaluate renal colics. Stone in distal ureter, difficult to differentiate from pelvic calcification or feculates. The urologist need to look other sign of obstruction like ureteral dilatation and inflammatory changes in upper tract को देखना पड़ता है इसमें. So low dose unenhanced helical CT has a specificity of 92 to 100% with a sensitivity of 96 to 100% for detecting stones, and offers 99% positive predictive values and 90% of negative predictive value for urolithiasis. So obstructed VJ stone. Mild dilatation in upper tract with this stone. Again, it's a pelvic stone and a lower calyx stone with hydronephrosis, thin out cortex. Again, renal stones with loss of cortex, renal stones with complete loss of cortex, and bilateral PUJ stone. Anyone can explain this?
You, Dr. Faisal.
This is a coronal section of CT KUB which shows right normal kidney ureter as well as some part of bladder, and there is an obstruction seen at the distal ureter with proximal dilated ureter as well as the pelvic helical system. So this is a distal ureteric stone with obstructed uropathy.
No, that's not Stanford. Absolutely not.
What?
After this lecture, please. ठीक है ना? अच्छा. There's a distal ureteric stones with proximal ureteric dilatations or hydroureter. You see that?
Again, proximal ureteric stone and distal multiple ureteric stone.
What is the definition of transpassible?
After that. ठीक है?
So these pictures of medullary nephrocalcinosis, located pictures on CT of medullary nephrocalcinosis.
What is nephrocalcinosis? Anyone? मैंने शुरू में भी कहा था it's an interactive session हो सकते हैं, rather than हो सकते हैं lecture हो सकते हैं.
The renal interstitium or the renal parenchyma.
Okay, जी Dr. Bilal.
Different differential diagnosis and causes, like in the case of infection, tuberculosis, pyelonephritis, glomerulonephritis, different causes like medullary disease, renal tubular acidosis. So it causes the deposition of calcium in these
In the
situations.
cortex as well as in the medulla, all those.
Yes, sir. Yeah.
Yeah.
Renal infection, role of CT and renal infection. Nephronia refers to an intermediate stage between acute pyelonephritis and renal abscess. It's a focal intestinal nephritis. Appears a wedge poorly perfused parenchyma. So again, a renal upper pole abscess. A cystic and solid masses. A simple cyst on CT has a Hounsfield unit of 0. If Hounsfield unit increases by 15 to 20 in enhanced corticomedullary or nephrogenic phase, it confirms the renal mass. The presence of fat which enhance less than 10 Hounsfield units is diagnostic of angiomyolipoma. So this is a parapelvic cyst, stretched pelvic cyst, a multifocal parapelvic cyst with a stretching of major chyle system. Look at.
What is
And
angiomyolipoma? Medical student, house officers. What is angiomyolipoma? Dr. Rabia, Junior. Yeah, Dr. Rabia.
So angiomyolipoma is basically fat deposition in the vessels.
Sir, time coming.
No, yaar, we finish it out. Simple as that. The last comment is, what is angiomyolipoma?
Fat deposition in the vessels
Okay. Only that is only fat?
and muscles as well.
Muscles.
Myolipoma. So.
Okay, madam, thank you.